Hello, and thank you for joining us. We're very excited to talk to you today about the interdisciplinary case-based approach to treating soft tissue defects using extracellular matrices. And we want to thank Integra Life Sciences for supporting this. The faculty will be myself, Claire Dillingham, the Chief of Plastic and Reconstructive Surgery at Cone Health Medical Group, Plastic Surgery Specialists in Greensboro, North Carolina, and Erin Testerman Mitra, who comes to us as a certified wound ostomy continence nurse, and she is coming from New York, New York. We have our disclosures there. Our learning objectives will be to examine the best practice uses, tips, and pearls to optimize extracellular matrix treatment outcomes. We'll examine cases on the use of the matrix and for soft tissue repair for a diverse range of acute and chronic wounds. And we're excited to get started. So the scope of wound care is indicated in all patients with surgical and traumatic wounds, abrasions, soft tissue or superficial burns. Really, anytime there's an incision made, a wound is created and wound infections are possible. And so we know that when we do surgery, there's always a chance for bacteria to be introduced. So we have to develop and apply new concepts to prevent and to treat the wounds if they occur from surgery or if they occur from trauma. According to the latest data from the National Center for Health, they performed a study in 2000 which showed a 31.5% of outpatient surgeries are performed, and a complex segment within the high need patient population are individuals who suffer from chronic wounds. In the US alone, chronic wounds affect approximately 6.7 million individuals with an excess of $50 billion spent. And we know that with an increasing population age and chronic disease, this number is bound to go up. It's estimated it will affect 8 million people. We've looked at one of the studies in the human wounds and its burden. It was an update, and it showed that there was an analysis of the Medicare patients with 8.2 million people having wounds, whether they were with or without infections, and the cost for those was in the $28 to $96 billion range. So this is a real challenge, also a great opportunity for those of us who are in the wound care world. The complexity of presentations of acute and traumatic wounds requires a multi-management approach with lots of different departments, from wound care nursing to reconstruction. We want to try to get the best looking wound, the most functional wound with the least amount of donor morbidity. We know that long-term scar responses have an effect on the overall healing of wounds. And so it's something that we keep in mind. When it comes to extracellular matrix scaffolds, we have a really neat study that was done a few years ago by the University of Pittsburgh, where they looked at 14 commercially available extracellular matrix-based products, including was the Matrastem. And what they wanted to do was look and see at the 14-day mark and at a 35-day mark to see what the donor response was, or the host response was to the different materials that were used. So it was placed on an abdominal wound, keeping in mind that the extracellular matrices are also used for abdominal defects. A lot of them are dermal tissue derived, and then they have cross-linking. Some of them, like the porcine dermis, has cross-linking that's done chemically. And by cross-linking a product, the natural structure is altered by chemicals. Glutathione is one of them. So what we found through this study was that there were basically three main types of responses that were seen in the host. There was either encapsulation, integration, or site-appropriate remodeling. And those pictures really show very nicely the difference from a histologic standpoint of what the body is doing, or in this case, the mouse is doing to the different responses. So in each frame, you'll see that the histologic image is showing the different type of host response. And then we'll go through and we'll see the 3 different types on whether or not there's encapsulation, incorporation, integration, or the host response. So when you have, in this slide, you see the histologic image of the device. It represents the different kind of the host response. And for this one, it's a classic encapsulation. And the response shows the foreign body response to the encapsulation, where the body is walling off the product that's used. And in this case, we see that the cells are not able to penetrate into the device on the periphery. So there's a restriction in the amount of host response you can get to the product that's used. And so that purple band is where that is then on the right side of the screen made larger. And there, you can see there's a thick fibrous capsule that's showed, that's noted both at the 14-day and at the 35-day mark. Then for the integration response, we see that there's, we have a dense collagen structure. It requires multiple steps and detergents in these products that were used. And for example, this is the porcine dermis. And so you have integration into the host tissue following the implantation. This product was Intazen. It's a non-cross-link form of porcine dermis. The cells were not able to break down or to remodel the device into the new functional tissue. So this scaffold did not elicit the formation of a capsule from the host, but on the other hand, it did not elicit the degradation of the product and the integration that we were hoping for in the product. When it comes to site-appropriate remodeling response, in this case, we show the porcine urinary bladder matrix. This shows a representation of matricem. In the histologic image for the 14 days after implantation, you start to see the mononuclear host cells in and around the scaffold. By the 35th day, there's actually no morphologic evidence of the scaffold. Instead, what you see are islands of mature skeletal muscle that have developed from the host. Now, we know that the mouse model is much quicker in remodeling than we would find in the humans, but it gives you an example of what you can expect over time. And the expectation for the human model is more of that 5 to 9 month period. So then from a unbiased approach, we had, or the study had, histopathology to review the different specimens and then to categorize them. Interestingly, they also categorized in much a similar way of the fibrous encapsulation or the foreign body response. Those, of course, received the lower score. But they also had the encapsulation, integration, and constructive remodeling. So it was interesting that it was found in that way as well. And so this was done at the 14-day mark and then followed for the 35 days. So the encapsulated group in general had the lower score, and this actually was the majority of the scaffolds that were invested and looked at. In fact, the only 2 products that fell into the constructive remodeling group were your Surgicis and your Matricem. And so you'll see examples of that in real life that we'll be able to show you coming up. I've got a few cases for you, and Erin's got some amazing cases as well. So let's talk about some clinical cases where we can look at some acute wounds and how we're going to address those. So this is a patient who was 51 years old at the time. This is a traumatic scalp injury. This is March in North Carolina. So March, it's still a little bit cool, 30s, 40s degrees. Her car had flipped over and she was resting on her head for over 24 hours on this cold March morning. So when she was found, she was hypothermic. She was brought into the emergency room. She had compartment syndrome of her arm. She was missing more than 50% of her scalp, which was not brought with her. So this was somehow degloved at the scene, or even with extracting her from the vehicle. So she underwent resuscitation. She was started on dialysis, and she had a amputation of her arm. So if we think about what we would do for this, and you might even be thinking now what you've done for patients like this, or what you would do if a patient like this came in while you were on call. And so we think about the scalp reconstruction ladder and the factors that we're trying to achieve. How big is the wound? How deep is it? Is there exposed periosteum? What's the quality of the surrounding tissue? Is there hair-bearing skin that we can preserve? What's the hairline like? And so we think about all of these things in regards to the physiology and the biomechanics of what's available and how we can treat the patient. This patient was taken to the operating room and debridement was done. She had quite a bit of destruction to the periosteum and the majority of the parietal bone, as you can see. So this was after it was cleaned and burred to get the punctate bleeding. And in the back of our minds, we are thinking about the old adage of the different layers, the skin, the connective tissue, the aponeurosis, the loose areolar tissue, and the periosteum. And we know that it's typical for avulsions to occur at that loose areolar area, because that's where it can come off. And so we hope when wounds like this happen that we at least have the periosteum intact, because we can do a little bit more with it. In this case, we didn't have that. And so this was actually one of the first patients that I have ever tried the urinary bladder matrix. And so the powder was applied, and then the 3-layer sheet was applied, and then a Daptic over that. And what you're looking at now is a 1-week post-op. And so keep in mind that she's still on the vent. She's trached at one point. She's still not very responsive. We're still not sure if she's going to make it because of her overall injuries and overall health. And so when I went to see her in the ICU and I saw this black, I was quite alarmed. And fortunately, I had an amazing rep with me who encouraged me to hydrate it, not to take it, not to debride it, that this was not non-viable tissue, that this was dried out urinary bladder matrix. So this is actually a great example of what happens when it dries out. Since then, I have learned that the scalp does dry out a little faster than most other portions of the body. And so I typically hydrate it twice a day. And so in this case, she was hydrated with Surgilube or hydrogel. And within a week, and then this picture is 3 and 4 weeks, with no debridement, just with hydrating, this is the amount of granulation tissue that we had. And so this is really encouraging because we know that the longer that the bone is left exposed, it's going to dry out, it's going to get denuded. And so to get this much granulation tissue this fast is really encouraging. And so at this point, the overall picture of the patient's improving. She's still on dialysis, but she's coming off the vent. She's waking up. She's doing much better overall, which also leads to her nutritional status improving as well. Here we are at 5 weeks, where micromatrix was applied additionally. And So here we are. So she had two occasions of reapplication of the micromatrix and one application of reapplication of the 3-layer sheet that was applied. And so here she is at follow-up 6 months, where on the right side, she had a skin graft. On the left side is her original injury. And this was at least 6 years ago. The patient has not required any additional surgery. There has been no breakdown, which was one of my major concerns for this patient, because I was concerned that because the bone was exposed, that even a simple scratch of her head would break it down, and then she wouldn't have the cell signaling around it in order for it to heal. And so fortunately, this lady has not required any additional surgery. She lives in a group home now. She's completely off the vent and living a fairly normal life. So very encouraging for such a large wound. If you do a lot of wound care, you have probably seen sternal wounds after CABGs. Fortunately, we don't see a whole lot of them, but when we see them, these patients are typically not tip-top healthy patients. Thus, they got the CABG. So in this case, the patient was a 61-year-old female. She had had a heart attack because of excess cocaine use. She had a stroke. She underwent a 3-vessel CABG, and due to the vessels that were used, local flaps were not going to be a great option along with her history. And so she had this sternal wound, and you can see, I'm not sure how big it is on your screen, but you may be able to see a tiny little bit of wire that was exposed. So my options were fairly limited because of all that we talked about. It was too soon to remove the wire. And so I needed to do something that would give her some time out from the surgery, with the thought that I would then need to remove the wire. And so we went to the operating room, did some irrigation debridement. It was a fairly clean wound, so not a whole lot of debridement was needed. She underwent placement of the ACell powder and the sheet. So it was the Cytel sheet and the micromatrix powder. And she had a 10 by 15 centimeter sheet applied, 3-layer sheet. And then she had negative pressure wound at 75 millimeter mercury pressure. And so when we think about these sternal wounds, we know that we want to get them covered as soon as possible, because we don't want there to be an infection or a compromise of the bigger surgery, the cardiac surgery that was done. And so we think about what are the risk factors? Well, of course, there's the possibility of a breach in sterile technique. The longer the operation, the higher the risk. If there's post-op bleeding and a requirement for a re-exploration, the risks are going to be higher of non-healing wounds. Any areas that aren't drained, even poor wound closure, excessive rewiring of materials, and obesity as well. Diabetes, age, hospital-acquired pneumonia, dialysis, prolonged ventilation. There are so many factors that are required with these patients that lead to increased risk. And so we look at what we can do to affect the healing and obtain it as fast as we can without risking other areas for the patient. Now, a lot of times these patients are candidates for pec flaps, omental flaps, rectus flaps. Again, in this patient, it wasn't. And in a lot of these patients, it may not be an option for various reasons. And so in this patient, we applied the sheets as we described, the negative pressure. And this was 1 week post-op. And you can see that there's a little bit of a looseness of the sheet. You can particularly see that at the top, the superior aspect of the wound. But we left that in place. and we continued with the dressing changes with the negative pressure therapy. And she did not require any additional matrostem or cytel placement. And here she is at 3 months, completely healed. And this is just an example of a number of patients that we've been able to treat with this. And I don't know if it's because of the location, because now they've got a pristine working heart, that there's good blood flow, but the patients end up doing extremely well with 1 and sometimes 2 treatments. But again, this patient just had the 1 treatment. So that's really encouraging and leads to a very happy CT surgeon. Okay, now what about clinical chronic cases? This patient in particular is a very, very sweet gentleman. He was 63 at the time, and he had diabetes. No, I'm sorry, he didn't have diabetes. He was a 3-pack per day smoker. And he came to the emergency room, not because he had a hole in his leg, but because his foot hurt. And so when he got to the vascular surgeon, they realized that he had poor blood supply, and he underwent a FemPop bypass and had a great pulse, great blood supply, but he had this wound. And so I got called to take a look at it. And so, of course, we think about our reconstructive ladder of the thirds of the lower leg, upper, middle, and lower, and what we have available typically for reconstruction, whether it be the gastroc, a soleus, or free flap. With a 3-pack per day smoker and a bypass patient, these and the location, these were not great options, unfortunately, for this patient. And so I said that I would be willing to give ACell a try and see what we could do, but that I was concerned, not having had a whole lot of experience with the ACell at the time. And again, this is several years ago. You know, I wasn't sure what to expect, because that black part that you saw, that was black denuded bone, non-viable bone. So we went to the operating room, we cleaned up the bone, we put a nice 6-layer sheet of cytel with micro matrix powder. So the powder goes down, then the sheet, and then you can see at the periphery of the wound on the left, that's the adaptic that's applied, and then negative wound pressure. And the negative wound pressure was set at 125 millimeter mercury continuous pressure, and we changed it once a week. When I started to see the periphery of the wound showing that granulation tissue, I was very encouraged. We weren't home free, but I was very encouraged. If you look at the right picture, that granulation tissue has grown over the tendon. The tendon was not excised. And so you can see in the peri-wound area, the entire leg is doing better from swelling standpoint and irritation. So he's really laying down good granulation tissue. Here we are at 10 weeks, where we've now at this point, we've got really great granulation tissue. The side picture is shown so that you can see how nicely it's filled in. At this point, I think that anyone looking at this and myself would say this is really ready for a skin graft. Due to issues with TRICARE that this patient had at the time, we were not able to do the skin graft. We were going through the process of authorization. We wanted to take the patient regardless, but he really wanted to wait until everything was approved for fear that we wouldn't get paid. That tells you what a sweet man this was. So we finally were able to get him skin grafted, and here's a picture of his 4-month post-op. Here he is at 3 years and 3.5 years. He did not have any additional surgery. He did not require any touch-ups, He didn't have any breakdown. He did so well. And this one I show you because that posterior part where the tendon was, that was native skin that healed over it. It wasn't grafted. That looks even better than the anterior view where his skin graft site got quite dark. But here he healed it right on his own. So he did a wonderful job and was so grateful. I will also mention that he was an excellent patient in regards to, he did stop smoking. And whenever we talk about wound care patients, we always talk about the other things that they need: multivitamin, vitamin C, zinc, increasing their protein, doing protein shakes, elevation as able when it's required and indicated for the area of the wound. And so all those things go in line with the things that we work on with our patients for optimizing the healing. And in this case, the ACell was really limb saving for this gentleman. So these are just a few of the many cases that I'm so excited about. And really, it's been a game changer for me in wound care. So thank you for your time and stay tuned. Erin is going to join you here in a minute, and you're going to really enjoy the cases she has for you.
Thank you so much, Dr. Dillingham. That was amazing. My first case study comes from the perspective of colorectal. I am a colorectal wound ostomy continence nurse. Therefore, I make recommendations for wound care. I have a really great team who respects wound ostomy continence nurses, and they allow our recommendations with very little contest. They really believe in, wound care from the wound ostomy continence nurses. So very thankful for my team. When I met our first case study, she was a 58-year-old female. She came to us from the GYN team. What happened was she had multiple bowel obstructions, and then they called colorectal so that she could come with an end colostomy. Unfortunately, because of her history, her surgical wound ended up dehiscing, and she formed an ECF. So she had a fistula within her surgical wound dehiscence. We saw her in the clinic. They decided to debride some of this little slough tissue, open up those sutures. And in the clinic, we decided that ACell should be applied with the intention of healing the surgical wound. We had no intention to heal the fistula with the ACell, but we hoped to get that wound more manageable. And we were afraid with all of her history, she'd have a very hard time healing. So what happened was the client would come back to our outpatient clinic for these applications. We started with doing some powder, then we'd add a thick Cytal sheet. We'd cover it with a non-adherent dressing, just for the idea that we wanted to keep the sheet inside of the wound. With a fistula, there's usually so much drainage, liters of acidic, awful fecal matter that just pours out of that wound because of the fistula. So we are deciding, how can we keep the sheet in? The urinary bladder matrix doesn't work unless it's inside of the wound to be absorbed. So we decided if I put this non-adherent dressing down and then kind of held it in with some hydrocolloid and then put a pouch over top of it to collect the fluid, it would help the urinary bladder matrix stay within the wound bed so that it could be absorbed. So you'll see my arts and crafts there, trying to hold in that urinary bladder matrix while allowing the fistula output to drain. These next few photos, you'll see some progression of wound healing. The client was admitted to the hospital for 2 weeks. She had failure to thrive. So I got to watch her a little more closely. I continued using the urinary bladder matrix. We noticed that the exposed bowel was definitely getting covered as the wound progressed to healing. Our output record said the fistula produced over 1 liter a day, but even with that much acidic fecal matter, we still saw the wound was responding to the urinary bladder matrix. It was absorbing the bladder matrix at a rapid rate, and we could see through the measurements how much smaller the wound was getting and how much healthier the peri wound was appearing. The patient was very encouraged by what she saw, and it gave her a lot of hope while she was with us in the hospital. After she was discharged, we continued to see her in the outpatient clinic. We continued using the urinary bladder matrix until we had no more wound depth to pack it in. Even after we stopped putting in any product at all, she continued to heal. And I was very happy to see her in the clinic and see that healing. We did notice that she was continuing to have tumor growth, but regardless of what medication she was on, her wound bed got smaller. And thankfully, the output from the fistula decreased to the point where we didn't have to pouch it at all, which truly was the best thing and the most surprising thing, since honestly, we weren't trying to do anything with the fistula. We were just trying to make the wound bed smaller and heal that surgical dehiscence. I always speak about interdisciplinary considerations. Since I'm a nurse, I work with surgeons, I work with other floor nurses, and everybody who's involved, I want to make sure they feel included, because these dressings need an interdisciplinary approach. The point of the dressing is to stay within the wound bed, so we need to include people so they know what it is, what to expect, and to help it stay within the wound bed. So our patient had multiple abdominal surgeries. She was on TPN and chronic IV hydration. She needed nutritional therapy, pain management, physical therapy, and infectious disease. She required a lot of emotional support, but she was very engaged in self-care. She was very receptive to wound care, even with her fistula. She was, very hopeful that her wound would heal. And honestly, it was just such a blessing to see, without any surgical intervention, that wound heal using only urinary bladder matrix. My next case study is a 74-year-old female. She came in for a lower anterior section. They created a loop ileostomy. Unfortunately, she needed to stay in the post-anesthesia care unit on a stretcher overnight. Very unremarkable recovery. Patient was sent home. We saw her for follow-up in our colorectal clinic. And when she stood up, we noticed dripping from her backside. So we asked her to turn around, and on her coccyx was an unstageable pressure injury, and it was very large. This was not noticed while she was in the hospital. This was not noticed when she was discharged from the hospital, but it was clearly there, and it was foul smelling, and it was very painful and seeping wet. We actually readmitted her, not only because of the pressure injury, but because she had failure to thrive. And there was no way she was going to get help for this pressure injury and for her difficulties with her ileostomy. So admitting her was the safest thing. Once she was admitted, there was a consult placed for surgical debridement. Once surgical debridement was performed, they did they saw how deep the wound was, and she was actually confirmed to have osteomyelitis at the sacrum. So we noticed the wound was, of course, larger. Once you debride a pressure injury that's that large, you know there's going to be a large amount of depth and tunneling. We initially started some negative pressure wound therapy twice weekly to control the amount of drainage. We thought it would help speed up some healing with her. She was with us for quite a while, and we did not see much change within her wound bed. We have some, some pink tissue, but we have a lot of adipose and a lot of depth. She begged me to stop the negative pressure wound therapy. She really hated sitting on the foam. She hated just the amount of wound care we needed to do with the negative pressure wound therapy, the wound vac. So we decided, let's try ACell. Let's try some urinary bladder matrix. We packed the depth, we packed the tunneling with both the powder and the sheets. And then we continue to assess the patient twice weekly. So even after the initial application, you can see that the tissues responded well to the urinary bladder matrix. You see some depth being filled in. We definitely noticed tunneling decreased. We continued with the application. You'll notice I have some hydrocolloid around the peri wound. There was quite a lot of drainage from her coccyx area, sacrococcyx, so we didn't have to hydrate as much as we had to contain the amount of drainage. So we put some hydrocolloid around the peri wound. We put a non-adherent dressing to, once again, hold the dressing in place. We want to hold that urinary bladder matrix inside the hole, being the fact that it's at her sacrum. Her sitting and standing and working with physical therapy definitely made it harder to work against gravity. So we had to make sure that we used enough secondary dressings to hold that urinary bladder matrix in place. Then we started discharge planning once the patient was healthy enough to go back home. Her measurements had decreased from her original sharp debridement. Her undermining and tunneling also were notably decreased. Our instructions were given to the visiting nurses who are coming to see her. And you'll see that our biggest goal was to contain the drainage, but also make sure that the urinary bladder matrix that we did place wasn't accidentally removed when they took off the secondary dressing. As you can see in the third picture, it can stick to a secondary dressing. So the idea is that we have to educate anyone providing care for the patient that we need to not throw away the urinary bladder matrix. It's still good. Even though it looks like something that you don't want to see in a wound bed, it's actually very healthy, and it needs to be replaced or put back in and then recovered with our secondary dressing to either absorb moisture or to provide enough moisture if needed. So even in the last picture, you can see that within a month, less than a month, some very impressive wound healing has occurred. Pain also decreased, and that patient was very happy to go home and to not have to use the wound vac. We continue to see the patient in our outpatient clinic. We did not have to put any further urinary bladder matrix when we saw her, but we got to enjoy that she continued to heal just based on the urinary bladder matrix that we did apply previously. And each time we saw her, the wound got smaller and smaller, and her pain decreased. And most surprising is the scar tissue around the area. And I worked with pressure injuries quite a bit. So scar tissue just literally means that I see patient with bone and scar tissue, and it's fragile, it's tight and stiff, and it usually causes a lot of pain. In her case, she wasn't complaining of pain. I was able to touch the tissue around and it moved. She was able to sit comfortably. And it was just very impressive to note that she wasn't just a spider web mass of scar tissue. For this patient, our interdisciplinary considerations are our patient was unable to take care of herself. She was failure to thrive, had low nutritional intake, quite depressed, muscle wasting, did not want to get out of bed. She was depressed and angry for the fact that she came in for a surgery, ended up with an ostomy, and then she ended up with a pressure injury, neither of which she expected when she first came for her initial surgery. So there was a lot of coaxing, there was a lot of trust development, and there was encouragement that needed to be placed into the patient for her to trust our recommendations for wound care and for her to believe that she actually was going to heal and get back to her quality of life pre-surgery. Her nutritional therapy was very important, pain management and physical therapy just to get blood flowing, to get these tissues moving. Our infectious disease team had to treat that osteomyelitis, and just showing her photos of her healing was truly inspiring to the patient. So trying to get her off of the negative pressure wound therapy, trying to get that proper dressing that wasn't so hard for her to manage and not hard for the visiting nurses to manage was very important. So this is where I speak about making wound care recommendations. So as a nurse, I'm not putting in orders. I'm asking a team to follow in my recommendations. I'm asking for the entire buy-in of the team. So generally speaking, as a wound ostomy continence nurse, after reviewing the patient history and doing the wound assessment, I have to reach out to an ACell representative to discuss product recommendations. In our facility, generally speaking, we do have some product in our Pyxis system in our ORs, but on the floors, we do not have a system to grab any urinary bladder matrix products. So our rep will bring it to us. Once we decide what products we're going to use and getting approval from our physicians and our surgeons, we decide the plan of care. How frequently are we going to change or assess the wound? Who is going to change it? What is our secondary dressing? And how are we going to educate the staff who also see the patient to what are they going to see when they walk in? What are they going to smell when they walk in? We generally utilize some really great written education, some great pictures, just so people understand when they walk in, whether it be a family member or the patient, this is what you're going to expect. And then we talk about documentation. So for our documentation, we generally say, we cleaned the wound, we placed in extracellular matrix or urinary bladder matrix. We explained to the patient what to expect. We explained to the patient, please do not let anyone remove this urinary bladder matrix because your body needs to absorb it for it to work. Most important is trying to explain to a patient that the wound will look different once we place this dressing. It may smell, it may look like a slough, it may turn tan or yellow, and there might be an odor as it's absorbed. That is all expected, and that is what we want to see, smell, and it will be managed. We'll put dressings to manage the drainage. We might have to add moisture if it's dry. In my case, most of my wounds are very, very wet wounds, so I'm trying to use dressings to absorb drainage. I always use non-adherent dressings over my my urinary bladder matrix because I want to keep that in place in the wound. We usually put a sign somewhere that says that the urinary bladder matrix was placed and please do not remove it. Sometimes we write on the dressing. And then some caregiver information is also left at the bedside. RN staff is updated. They put it in their communication handoff. It's in the chart, it's in the orders. And we generally just try to make sure everybody feels involved, and that way no one accidentally removes the dressing because they think they see slough or they smell something that is concerning to them. For discharge planning, we will hand out more information. We include the date that we applied the urinary bladder matrix. We include the date of when we plan to see this patient again. We do the nursing orders, whether they be visiting nursing care. That way they can also feel included. They don't come to a patient's home without knowing what this product is. We do leave instructions that say, please don't remove the urinary bladder matrix from underneath the adherent dressing. Sometimes we'll use things like Xeroform or Mepitel or Adaptic. So as I take off a secondary dressing, whether it's an ABT pad, gauze, or one of those nice foam dressings, once they hit the non-adherent dressing, they need to stop. They need to leave that alone and leave the non-adherent dressing in place. We always mention that what the ACell may appear as it absorbs, and not to be alarmed. And then we give them a contact information to reach out if they're confused or if they're really concerned. A lot of visiting nursing services think that the wound is purulent, or they think that there is slough. And we had to encourage them, no, I placed ACell or I placed the urinary bladder matrix, and I know it's there, and I plan to see this patient on this date. So please just change secondary dressing. And thank you so much for contacting me. I'll let you know how the wound progresses. So it's a lot of just team building when we start using dressings like this and send patients out into the home. It's best if you can kind of find a way to absorb the drainage without disturbing the urinary bladder matrix. So just kind of updating the team members as they come into the patient's picture is a really good way of actually getting this product to work. It needs to stay in the wound to work. And that's all I have to say. Very happy to take questions. Me and Dr. Dillingham the floor is open.
Hello, and thank you so much for joining us today. We appreciate you taking the time out of your busy schedule. I know Erin and I have enjoyed putting this together. So let's go straight to some questions. One question that's oftenly asked is about the vascularization. And so you saw that one of the examples showed a patient who had exposed bone. And so one thing that is asked is, well, how do you get that vascularization there so that the ACell, either the powder or the sheet, will start to incorporate? The big thing there is you need to have a nice, healthy wound bed. So if you have bone exposed and there is already periosteum there, then you can add the sheet of the powder right to that. If the periosteum is not there, then typically what we'll do is either burr down or rongeur down to punctate bleeding of the bone, and that gives you a nice vascularity for the blood supply to start working. And we've seen that on long bones, and we've seen it on the skull as well. So great question. Another question is in regards to the timing of laying down the ACell product. So when you are debriding a wound or getting a wound ready, a lot of times people will say, well, how do you know when to go ahead and add it? Do you need to wait until all the bacteria is gone? And the answer to that is, if you take a patient to the OR and you debride the wound and you get it clean, you've used either the saline or you've used antibiotic ointment or antibiotic solution to clean the wound, and you feel confident that you've gotten a nice clean wound, then I want that healing process to start. So I go ahead and add the powder and the sheet and start the process. It's not very frequent at all that I come back or I look at the wound at the next visit and say, oh, I shouldn't have added it. 99% of the time, I'm so glad that I went ahead and started that healing process. And Erin, you want to take this one? Adding the powder prior to the sheets?
So the powder absorbs very quickly within about 24 to 48 hours easily. So it will get into the actual wound bed very rapidly. So if whether you have only one opportunity to put in a product, the powder is just a shredded version of the Cytel sheet. So that absorbs quickly, where the sheets will take longer depending on which layer you choose. So 2-layer is a pretty thin sheet that absorbs within a couple of days. If you don't think you'll see the patient for weeks because of follow-up issues, or you're placing it under like a negative pressure wound therapy, you can go up to like a 6-layer sheet because it will slowly metabolize over time.
Excellent. And so why we use bladder, the question is why we use bladder, extracellular matrix, as opposed to maybe placenta or even bowel. So we do use the other products for sure. I think that there are benefits to all the products that are out there. The reason for the extracellular matrix of the pig bladder in these cases that you've seen is a lot of times if I need a wound to start filling in, if there's a big depth difference in the wound, the ACell lays down and helps the body lay down granulation tissue quicker than any of the other products that I've used up to this point. And Erin, have you seen that to be true?
I have, and I understand that there's other opportunities for like 3 to 30-degree burns or things where other tissues, such as the bovine or placental tissues, may be used. But for cavity wounds, the bladder matrix really works well for us.
And we do like using the powder and the sheet together. There are a couple of reasons for that Erin mentioned. Using the powder, you're going to start getting that incorporation very quickly within a day or two. If you're only going to be able to go to the OR once or maybe even twice, that incorporation of the powder is so quick that you're a little bit not utilizing everything you could utilize. And so the sheet's going to give you that longer lasting effect. So I typically go with the 3-layer sheet. I get that 3-layer sheet down over the powder. That does a couple things. It protects the powder from being wiped away or even blown away from the wound. The sheet helps to protect that. It also helps to give another week or 2 weeks of stimulation of the body to lay down that granulation tissue. The 6-layer is that may last you a month or two. And you may not need that much. You'll have to be a lot more patient with the 6-layer, but typically I will use both the powder and the sheet. The other reason for both the powder and the sheet is a lot of times I have such a depth difference in the wound that when I put that sheet down, there's going to be areas where it's buckling or not adhering, and the powder helps to get a nice layer and a nice even foundation to that base. So we really like that too. There are also, or have been in the past, issues with compensation for powder only versus powder and sheet. So that's something to think about when you go to the OR that could affect reimbursement. So just something to think about. And when it comes to like how long do you leave the matrix in place, leave it. Don't be tempted to take it away. I know Erin is going to comment on when it turns black. You go ahead, Erin, because I know you like that.
Hydrate it. Keep it hydrated.
Keep it hydrated and leave it alone. You when you first start, you're going to be so tempted to peel that black off, thinking it's eschar, and it's possible that it is. But if it's just been a week or two, it's probably ACell that's been dried out. Hydrate it at least once a day. Sometimes you need to do it twice a day, and just make sure that doesn't dry out. And you'll be so surprised when you come back in a week, if they've been doing that hydration, that you will have all of a sudden nice red, pink granulation tissue. But we really want to thank you for joining us today. We've had such a nice time doing this. It's always great to see Erin. I always learn from her talks. I'll see if we can get her back down here in North Carolina. But stay tuned. There'll be welcoming remarks from the SAWC co-chairs and the WHS president. If you'll stay tuned to listen to those comments. And we are so hopeful that we'll be able to see you in person next year in Las Vegas when we're all back together and we can pull off our masks and have a mask burning party. Won't that be nice?